This video touches on the topic of suicide. You might be coming to this video as a researcher or suicidologist who engages in this subject matter in your work, as a survivor of suicide or suicide loss who has been personally impacted by this subject, or as a policymaker looking to translate research into policy. However you're showing up today, the topic of suicide can evoke a deep pain and emotion. Before we begin, I'd like to start with a few grounding reminders, borrowed from Dr. Jeffrey Anslus. You may want to consider checking in with yourself to decide how and when to best watch this video. Maybe you want to watch it with other people. Maybe you want to watch it in the morning and not late at night. We invite you to bring a good heart, a good mind, and a lot of compassion for all as you watch, including yourself. Feel free to take a moment now to pause, reconnect with yourself, and reflect on how you plan on engaging with the content today. There are resources available to you should you want to talk to someone. Depending on where you are in the world, those resources may look different. In the description of this video, we've provided some places to start, with options to get help for yourself and help with supporting someone else. This video touches on the topic of suicide. You might be coming to this video as a researcher or suicidologist who engages in this subject matter in your work, as a survivor of suicide or suicide loss who has been personally impacted by this subject, or as a policymaker looking to translate research into policy. However you're showing up today, the topic of suicide can evoke a deep pain and emotion. Before we begin, I'd like to start with a few grounding reminders, borrowed from Dr. Jeffrey Anslus. You may want to consider checking in with yourself to decide how and when to best watch this video. Maybe you want to watch it with other people. Maybe you want to watch it in the morning and not late at night. We invite you to bring a good heart, a good mind, and a lot of compassion for all as you watch, including yourself. Feel free to take a moment now to pause, reconnect with yourself, and reflect on how you plan on engaging with the content today. There are resources available to you should you want to talk to someone. Depending on where you are in the world, those resources may look different. In the description of this video, we've provided some places to start, with options to get help for yourself and help with supporting someone else.
Thanks for signing in to the Suicide Care Research Center Methods Core Seminar Series. I am Molly Adrian, representing the Methods Core for the Center, which is supported by a talented and diverse group of researchers representing a variety of fields, including psychology, health services, biomedical informatics, statistics, and human-centered design. The goal of this presentation today is to orient investigators interested and supported by the UW Suicide Care Research Center to the measures used to harmonize data and required to be collected where it makes sense by the center. This is of critical importance because the Methods Core is seeking to integrate all of the data from the 12 projects comprising the Suicide Care Research Center to make bolder and more comprehensive conclusions about suicide care intervention components that comprise the elements of the suicide care pathway. With that in mind, my goal today is to talk about the minimum data requirements for projects that are funded by SCRC and orient to the core measures used across the proposed intervention and implementation mechanisms, as well as our intervention outcomes. The evaluation of the Suicide Care Research Center research activities, as you all know, focus on the suicide care pathway. So the figure here illustrates that pathway, and the top row outlines suicide prevention activities that could occur in the outpatient healthcare setting. And this ranges from risk detection to long-term follow-up. Our model that the center is focused on also articulates that each point of the care pathway is influenced by the acceptability and usability of the intervention. These are our implementation mechanisms, as well as the therapeutic alliance and self-efficacy between outpatient healthcare providers and their patients. So therapeutic alliance and self-efficacy are our intervention mechanisms. So usability and acceptability of intervention components are the mechanisms to improve therapeutic alliance and provider self-efficacy. And ultimately, we believe that this influences the reach of interventions. Otherwise stated, the more providers feel confident and connected to their patients, the more pathway practices will be used and more suicidal patients will receive them. So these proposed mechanisms both directly and indirectly result in improved suicide outcomes that are most meaningful for adolescent and young adult patients. And we are specifically focused on reducing suicidal thoughts and behaviors, reducing unnecessary referrals to the emergency department, and greater satisfaction with overall care. So although reach is in our theoretical model, we believe that it's beyond the scope of the center to measure reach in a valid way. And so that while it's in this model, I won't be talking about the measurement of that construct today. We refer to measures that are required and included in the center's data repository as the Suicide Care Research Center Common Data Elements. So you may hear center faculty and staff refer to SCRC CDEs, our Suicide Care Research Center Common Data Elements. So the majority of projects that are in the center will be in the preparation phase of most and have goals of understanding the context and needs related to suicide care. So these projects have a range of goals, but can include specifying optimization criteria, understanding key constraints, developing conceptual models, and candidate components, as well as the design solutions to the barriers to implementing suicide care processes. So most projects will be using human-centered design for as an iterative process to understand the key implementation mechanisms. And for the SCRC, these implementation mechanisms that are specified are around usability, acceptability, and feasibility. So we require measurements of acceptability and usability at each phase of the most framework. And we strongly recommend that you collect feasibility data as you're allowed. So thinking about usability, this is the degree to which interventions can be used with ease, effectiveness, and satisfaction. And we have two ways that we will be collecting this data, and we're asking SCRC investigators to collect the data. So one is a quantitative measure that is completed by the end user that makes sense given your project. And so this could be a clinician, a primary care physician, an adolescent or young adult, or a caregiver. And this measure that we have required is the system usability scale. So this has been used in other centers like the UW Alacrity Center and is a well-established instrument in HCD work. So we're asking for this brief measure to be completed by your end user. And in addition, the methods core is also asking research teams to report their overall impressions of usability issues. So we would like you to complete a brief REDCap survey when you encounter a usability issue that you think is of high importance and high impact. And it's very, very brief. So we're asking you about what DBT stage you are in and what the usability issue that you've identified and sort of your rationale and evidence for this being a usability issue that would be prioritized for redesign. Then the methods core is going to consolidate that information, code it, and provide center-wide conclusions. So it's really very helpful that research teams do that. Our second implementation mechanism is around acceptability. And acceptability is the perception that a specific suicide care activity or component is agreeable to use. So we are asking people to use Weiner's instruments, and so this is the acceptability of intervention measure. This is a really brief instrument that is 4 items and asks about its agreeableness, its satisfaction, its how much they liked the intervention. And this we will have research teams make specific to their protocol. So you'll make some changes in that instrument to identify the specific aspect of the intervention that you are asking people to comment on. And that's what we'll be using for our acceptability quantitative data. You can, of course, augment this with other qualitative approaches to understanding acceptability. And finally, as an optional measure, we are also recommending but not requiring that people collect feasibility data. So the information around an intervention, its use in a specific context. And again, we've adopted Weiner's brief measure called the feasibility of intervention measure, and that is a 4-item questionnaire that again will be more specific to your intervention. So you'll make some changes in that measure to specify the specific area in which you're wanting respondents to communicate their feasibility data. In addition to understanding our implementation mechanisms, projects may also focus on intervention mechanisms. So as I noted earlier in the presentation, there are 2 prioritized mechanisms for suicide care interventions to impact suicide risk outcomes in the center. And the first is therapeutic alliance, so the sense of collaboration and bond between a provider and their patient. And we have selected the Helping Alliance questionnaire 2 for this construct. And the HAQ is a 19-item questionnaire that's rated on a 6-point Likert scale and is completed from the perspective of both the provider and the patient. The second proposed mechanism is around self-efficacy. So depending on your study goals, you may be targeting self-efficacy to increase for caregivers or patients or providers. So there are 3 different measures by the target audience. So we're asking that providers complete the provider suicide intervention questionnaire to understand their attitudes and behaviors about treating suicidal adolescents and young adults. If your research project is involving adolescents and young adults, then we ask that they complete self-efficacy measure around the suicide-related coping scale. So this scale is a 17-item questionnaire regarding adolescent and young adults' ability to manage a suicidal crisis. And so is developed by Barbara Stanley and has, reliable and valid psychometrics, and we believe would be a good representation of the adolescent and young adults' specific self-efficacy around their managing their suicidality. And finally, we're asking that if you are obtaining data from caregivers, that they complete the Parent Suicide Prevention Self-Efficacy Scale that was developed in Cheryl King's lab and is a 12-item scale reflecting a caregiver's confidence in caring for their suicidal adolescent. Finally, and very important for our center, I'd like to talk a little bit about our intervention outcomes. So we are, of course, most interested in reducing suicidal thoughts and suicidal behavior, and have spent a fair amount of time understanding the literature for measurement of suicidal thoughts and behaviors in this age range, and also considering the practical implications of measures that could be adopted in primary care, given that that's the destination setting in which we are most focused on. So in order to understand changes in suicidal ideation, we originally had proposed the suicidal ideation questionnaire that is commonly used in clinical trials with adolescents focused on suicide risk. And we have changed course on that measure because of some practical barriers with cost and translation. We instead are now requiring the HAWS, which is the Harkavy-Asness Suicide Scale. And this is a self-report measure that has been used in other clinical trials, including Jonas Sarno's and Anna Radin's, and assesses a broad range of suicidal ideation. The psychometric qualities, its free cost, and the explicit design for self-reported outcomes for youth was the reason that we had switched from the SIQ Junior to the HAAS. And we are using just the suicidal ideation scale. So the original measure consists of 21 items, and we are using the 12-item suicidal ideation subscale, and we'll be assessing behavior items with the Columbia Suicide Severity Rating Scale. So you can see the preview of the HAAS items here. It has a broad range of ideation items that really vary from passive ideation items such as I thought life was not worth living, or that I would be better off dead, and increases in severity to active ideation, including ideas about killing yourself or being in high places and feeling like jumping. This measure is also, people respond on a Likert scale with frequency from never to most or all of the time. And so we believe that this measure will be give us a good range of ideation, severity, and frequency for the populations included in SCRC. In order to practically and accurately capture suicidal behavior, we are using the Columbia Suicide Severity Rating Scale, a self-report version. So we have augmented the 6-item standard screener to help ensure that we're capturing the constructs of interest and that it is developmentally appropriate for all of our participants ages 13 to 30. So we augmented questions in item 6 with prompts from the full interview version of the Columbia Cognitively Impaired and Very Young Child version. We used screener format and decision rules to help move people through the survey with ease. And so the result is at baseline. The measure is intended to capture both recent and lifetime assessment of suicidal behavior. And the original prompt for behavior around item 6 includes lifetime preparation, aborted, interrupted, and actual attempts. And then if that is endorsed, we ask clarifying questions around what the behavior was, when the timing was, and a brief description. This is incorporated for any behaviors that have happened in the past year, including the most recent and the most severe event. And follow-up, which is standardly at 1 and 2 months for center-wide data collection. The Columbia assesses behavior since last assessment, and so they have detailed questions assessing the most severe attempt if they reported multiple attempts, as well as the most recent if it was not also the most severe. So the intent is that the self-report version is understandable and efficient for participants, while also being able to distinguish among different suicidal behaviors with accuracy. Most investigators will also want to capture some demographic and descriptive information from their participants. We ask that investigators use our standard measures to capture the common data elements across the center. And so 2 of those prioritized moderators are around functional impairment and demographic and social determinants of health. For functional impairment, we have a 5-item measure that asks about health-related quality of life. And we have selected the youth version to be used across the developmental spectrum of participants in the center. And then for demographic and social determinants of health, we have used items from the Phoenix Toolkit and have selected items that are of highest relevance and importance for the center. So we have, as you would expect, race, ethnicity, gender identity, sex identified at birth, or sex assigned at birth, excuse me, and some income, occupation, and health access and literacy questions. Investigators are also welcome to add additional constructs to their data collection, but please do not alter or change the demographics that will be pre-populated in your REDCap data dictionaries. So that brief 20-minute orientation has summarized the required measures that we are asking investigators to use if their projects are supported by the Suicide Care Research Center. At the Methods Core, we are really eager and invested in your success and would like to support you across your research journey. And so there are several resources that I would like to point you to. You can request consultation with us using our email address. There are also documents in SharePoint that outline Methods Core resources and recommendations for measures that are not required. So for example, if you're going to be collecting depression symptom inventories, we ask that you use the PHQ-9, given that that's commonly used in our PCP setting and is widely available. We also have processes for giving investigators their REDCap data dictionaries, so to jumpstart their REDCap build and ensure that we have consistent variable names and measures across our studies. And of course, we're happy to consult around your approach for your study, ways to make the most of your research funds, and talk about all things data analysis and harmonization. Thanks so much for joining today.
Thank you for watching this seminar from the University of Washington Suicide Care Research Center. Please take a moment to complete the anonymous evaluation to share your feedback. If you would like to receive a certificate of completion, be sure to also complete the attestation. Links to both surveys are available in the description of this video. Your input is much appreciated. Thank you for watching this seminar from the University of Washington Suicide Care Research Center. Please take a moment to complete the anonymous evaluation to share your feedback. If you would like to receive a certificate of completion, be sure to also complete the attestation. Links to both surveys are available in the description of this video. Your input is much appreciated.